review this at a later date. And now I'd like to turn the screen to Rabbi Zachary Goodman, Assistant Rabbi at Holy Blossom Temple, who oversees numerous programs at Holy Blossom, including those that provide social connections and support within our community. Welcome, Rabbi Goodman.
Hello and welcome, everybody. Thank you, Julie. And on behalf of the Holy Blossom Temple's Luke Sklar Mental Health Initiative, I want to thank everyone for joining us this evening. Just before we really jump into this fantastic content, I wanted to just take a very brief moment to address why is it that Holy Blossom Temple is addressing this particular topic. What is exactly Jewish about mental health? What is Jewish about trauma? So it's very important to note that I am not a mental health professional, and I approach these topics from a place of spiritual concern rather than medical science. Though I do believe that mental health, and particularly this growing and healing from trauma, offers a really interesting intersection of the fields of science and religion. And so when we look at our history, just a quick scan of Jewish history, it does not take much to realize that the Jews, both as individual Jews and as a collective people, the Jewish people, have undergone a wide array of traumas over the years. The Holocaust is arguably the most traumatic event in the history of Jews of European descent. And as our survivors are aging, and many who managed to suppress trauma early in their lives, as we're aging, we're finding many are suffering with post-traumatic stress, other issues related to early childhood trauma. And the Holocaust is far from the only collective trauma of the Jewish people. We can look at the entirety of history, but also more contemporarily, the state of Israel has numerous experiences with terrorism, with war, and this has left a mark on many of the citizens of Israel, and of course, many of the friends of the state of Israel. And this is a double-edged sword here because of this trauma, Israeli doctors have become world experts in treating trauma. And the Jewish state often sends trauma experts to countries when dealing with the aftermath of natural disasters or pandemics, terror attacks, and other crises. So over the last few years, over the last 3 years or so, the Luke Sklar Mental Health Initiative has hosted a number of events and webinars dealing with a variety of mental health and wellness topics, including depression and addiction, anxiety, resiliency, and a few more. And as our society is now facing this collective trauma of the pandemic, and as we are starting to see what lies just beyond this pandemic, the members of this initiative found it crucially important to address where we've been and where we can hope to go on this collective journey. Maybe just one last word of gratitude. We are grateful to the Jewish Family and Child Services. This is a multi-service agency that strengthens and supports individuals, children, families, communities by increasing safety, increasing security, improving mental health and wellness, and reducing the effects of poverty within the context of Jewish values. And so we are joined this evening by 2 social workers who are available to speak with you should you be triggered by any of the topics that we are addressing tonight. Dana Frischman and Marina Gendelman can both be contacted at their email addresses, which I will post in the chat box in just a quick minute. JFNCS also offers a number of counseling programs with skilled social workers that can support in areas of trauma, areas of women abuse and domestic violence, separation and divorce, death and loss, as well as family counseling. So you can connect with a professional by calling their intake line, which is 416-638-7800, extension 6234. And again, I'll share that in the chat as well. So at this time, I'm going to turn it back over to you, Julie, and so we can begin learning from Dr. Andermann. Thank you.
Thank you, Rabbi, for giving us once again the Jewish lens on trauma and hopefully recovery. I'd like to introduce you now to our expert speaker on trauma. Dr. Lisa Andermann is a psychiatrist at Mount Sinai Hospital, where she has worked in the psychological trauma clinic, as well as on the ethnocultural assertive community team. In addition to this, she is an associate professor and co-chair of the Equity and Inclusion Council in the Department of Psychiatry at U of T, and is the co-founder of the New Beginnings Refugee Clinic at CAMH. Please welcome Dr. Andermann.
Thank you so much to Julie Solomon and to Rabbi Goodman, and also to the Luke Sklar Mental Health Initiative, and also to the social workers who are here this morning from this evening from Jewish Family and Child, for making time for this important topic and to be able to learn together. And it's a topic that is very close to my heart, and I'm happy to share some of the things that I've learned along the way from my own personal family story, from the patients that I've worked with at Mount Sinai, from some of the refugees and newcomers that I've had the privilege of helping, and also some of the outreach work that I've done with Inuit and Northern population. So I did just want to say a word of gratitude that we are all newcomers and settlers on this land here in Canada, here in Toronto. We all come from somewhere else unless we're part of the First Peoples. So I do just need to see if I can share my slides, because we practiced that before. So I'm going to try to do that right now so that we can get started. Can you see? Great. Let me just move this down to the bottom. Okay, so trauma, healing, and growth. So we'll be speaking this evening, going over some ideas like what is trauma, understanding the range and impact of trauma on individuals, appreciating the situational and individual factors that might predispose to the development of psychological trauma, and also to think about a focus on resilience and how we heal and grow after adversity with some refugee, Holocaust, and COVID examples. So I'll start with resilience after Holocaust trauma. And this is a quote from Joel Sadaboy, who's a psychiatrist at Mount Sinai, working with the geriatric population. And Rabbi Goodman just spoke about how many of the Holocaust survivors are advancing to old age. But he takes a positive message from this, saying that all of us working with elderly or traumatized Holocaust survivors really are inspired by the unimaginable strength and resilience of survivors in overcoming adversity, recreating their lives, and living in their old age. And like we say in my family, like they just don't make it, they don't make them like that anymore. Like people really had survival skills and grit and determination to get through what they did. And to make meaning and kind of understand some of those experiences, I think we have to go like beyond the confines of medicine and the biomedical perspective, maybe moving into spirituality and Rabbi Goodman's area, and think about social suffering, which is really an interdisciplinary study of difficult events, whether it's war, famine, or other difficulties seen through the lens of history, literature, medicine, also anthropology, and religion and social medicine, all woven together. So I'll just get this slide up and then say a few words. You know, we know that suffering is not usually located in an individual person, although in the West, we do have the tendency to see a person as a victim or as a patient. We know that certain mental and social problems have these social roots. And when we medicalize those things too much and give a person a diagnosis rather than looking at the bigger picture of political and social situations, then sometimes we can mask a little bit the larger view. And Viktor Frankel was someone who was very thoughtful about this. People know he's a Holocaust survivor. He was a psychiatrist and anthropologist. He survived Auschwitz. He wrote about the search for meaning and wrote that in times of crisis, people reach out for meaning. Meaning is strength. Our survival may depend on our seeking it and finding it. And in my family, I had my own survivor story. My grandmother, Dr. Mina Deutsch, who was a physician with my grandfather in Poland, and they met and went to medical school in Prague in the 1930s, and then came to Canada after surviving the war, not in a camp, but in hiding, and built a new life in Canada. And, you know, that has really permeated a lot of my views on life and the kind of work that I'm doing now, and probably is directly related to the reason that I'm working with refugees and newcomers, and have focused my career on working with trauma. So just a couple of details about her life. She came from Poland, in a part of Poland that was on the edge of Russia and Romania. All of it is now today in Ukraine. And as I said, spent her student days in Prague, where she married my grandfather. Went to medical school. Just think in the 1930s how many women might have been in her class in those days. And, you know, had to make a new life in Canada after the war, learn a new language, retrain in medicine, which is a very difficult, not a very portable skill, and not easy to get the credentials. She was actually at the old Mount Sinai Hospital here in, I think, 1950, when it was in Yorkville, before it moved to University Avenue. And I think my family has tried to make meaning of her experiences by traveling back to the past, going back actually with her 50 years or so later to the villages where they had spent the war. We met some of the people that they had known in those times. We met the buildings. Things really looked like they were frozen in time, like people were going around with horse carts, and you know, it really felt like some things had never changed. And after she passed away in 2003, we were able to go back later, actually with her book. You can see it in my brother's hand, and actually, you know, meeting some of the family members of the family that had hidden and saved them, and going back yet one more time, this time just my parents, to have a ceremony for the righteous among the nations to recognize with the Yad Vashem Museum the people that had saved their lives. So this kind of meaning making also from my father's side of the family, you know, I think things that we can do to understand the past, to keep track of memories through photo albums, through cookbooks, through working on different projects. Now they have all these like genealogy online searches that you can do, being part of groups that are interested in looking at the past is so important, because we know that, you know, even today it's a different new century, new times, but there are people knocking on the doors to come to Canada who are waiting in Afghanistan and waiting in lots of different parts of the world. And for them, it's like a lot of this happening like it was during World War II. So that's the end of my personal preamble. And now we'll think a little bit more formally about what trauma might mean. Oftentimes we're thinking about pictures like this: big chaos, disruption, and sometimes war, natural disasters. In the more recent year and a half, we've thought of things that might look more like this. Our lives have been turned pretty much upside down, doing things that we never thought we'd have to do, staying in our homes, going out to places wearing masks, getting tested all the time, getting really tired at work, lots of different things. If we are even going out to work in person, like things we never thought would be. So I'll move to a definition of what is trauma, and then we'll also talk a little bit about what it is not. So trauma, first of all, is a word that we use colloquially in English all the time, but trauma is really about fear. And unresolved trauma is a lasting response that results from living through a distressing or fearful event that can harm a person's sense of safety, sense of self, and ability to regulate emotions and navigate relationships. And so people with unresolved trauma can often feel shame or helplessness, powerlessness, and intense fear. I mean, fear that even, you know, makes it hard sometimes to go out and get your mail, go out to a doctor's appointment, go out to meet people. People's lives can shrink until it's very difficult to, to really go and have any kind of social network or connections. But it's very difficult to define what trauma is because it's different. People experience things in different ways. It depends on your reaction to things. It depends on your past life experiences. And so it's very hard to put a label on what events might be causing trauma and what are not. We also know that there is individual trauma, collective trauma, where a whole group goes through something like the COVID, but maybe not the same as if we were ICU physicians. People have their own kind of small groups where they might experience things together in common ways. There's also intergenerational trauma, and people are talking about that a lot now with the residential schools, but people have also written about it in terms of Holocaust survivors as well. If we look at a diagnosis, like a psychiatric diagnosis of trauma, and according to the book, which is the DSM-5, where all the psychiatric labels are kind of described, their definition of trauma is very narrow. So it's actually a very specific thing: actual or threatened death, serious injury, or sexual violence. So they kind of really limit it to things where like you're at risk of life and limb, not so much losing your job or going through a marital crisis or watching bad things on the news or having things happen kind of so much around you, but really kind of going through it or somebody directly connected to you going through it. And when it comes to COVID, I think the literature is still out. It's kind of too soon to know, but we need to remember that exposure to stressors most commonly lead to things like depression and anxiety rather than PTSD. We also need to focus more on things like burnout and coping. There's also some new data out showing that, for example, suicide rates fell 32% in the first year of the pandemic. I'm not sure all the reasons are known, but maybe because in Canada there have been some financial kind of compensations, the CERB and other benefits that have kept people's heads above water, whereas maybe in other countries there's been less of that kind of safety net. And that's a very important part of coping through these kinds of unprecedented times. You might see a lot of articles like this calling things like post-COVID stress disorder. I don't know if that's really like a thing in terms of psychiatric diagnoses, but if you look at, which of the issues kind of seems the most prevalent, it is anxiety and depression. Maybe people are coping a little bit more with substance. You always have to be careful thinking about hopelessness and suicidal thoughts. And trauma and stress-related disorders, we don't know if those things are really new in people that didn't have them before the pandemic, but certainly people who did have problems with mental health before, after a disaster or after a big event like this might have more problems. Whereas, it's not so clear. People who were well before and have good protective factors, as you see in the top of the right-hand side, social support, a job, a safe home, a network of people around them, might not come out of it so badly. So this curve, maybe I need to move this in case it's blocking the slides for you. This burnout curve is really one of the things that we need to think about a lot. People working themselves into mental and physical exhaustion and going down and down without being able to get back the same kind of satisfaction with their work and energy, recharge their batteries after work or on the weekends. And then it may start to creep in to the rest of people's lives. So building resilience during COVID, this is from a project at Harvard that gave an analogy of like a seesaw, where you either try to lighten the heavy side of the seesaw, where there's closed schools, job loss, things that are not going well. You try to up the positive side of the seesaw by giving like these CERB unemployment benefits or helping people with housing. People were getting some internet and electronic devices, things like that. And you can also think about a third way of managing this is to slide the fulcrum, like the triangle at the bottom of the seesaw, moving it so that you can get a better balance. So the more stress somebody is under, the more support is needed. And we know that also some anxiety can be good in life in general. Otherwise, like, why would people be here after dinner on a Monday night, listening to this lecture? There is, we need some stimulation to get to an optimal performance. And athletes would know this, or anybody who's a musician, or, who's getting ready for a performance of any kind. Otherwise, you're at boredom on one end and ready to fall asleep, or you're kind of burnt out and exhausted at the other. So, it's not like all stress is bad. Some stress is actually good. But when we're faced with a life-threatening situation, or something very kind of out of the ordinary, we go through as human beings and as mammals, a cascade of fear defenses. People have heard of the fight or flight response. There can also be a freeze, like deer in the headlights response. And then there's a kind of recovery time. And so a lot of this, can be dealt with as normal reactions to abnormal events. It's normal maybe not to sleep well the first night after something happens. Maybe you'll have a bad dream, but those things are different than PTSD for sure. And they're different than, having long-term consequences after a trauma. So a question for the audience, I guess I could have put this on a quiz, but we didn't do that. Does everyone who's traumatized get PTSD? And the answer is really no. So in the general population, and these are statistics from the States a number of years back, more than half the people have had something of a serious event, like a diagnosable kind of criterion A event in the DSM, but many fewer, 5% of men or 10% of women may have a diagnosis of PTSD after those events. And what happens to everyone else? Well, they actually recover over weeks or months, and sometimes years. People do start to get better. And sometimes that's with professional help. Sometimes that's with support, spirituality, lifestyle, different kinds of means, but people do recover. People who are in this unrecovered right side of the slide are the people who may need specific kinds of help to move through to recovery. And PTSD has been around with various names for many years. It started really being described in World War I. It was called shell shock or combat neurosis. After World War II, with Holocaust survivors, it was called survivor syndrome. And it's a fairly new diagnosis in terms of the psychiatric literature, and came into being after the Vietnam War. Only in 1980 did it become an actual diagnosis in the books. And we think about a couple of different categories of symptoms. There's re-experiencing, like I said, nightmares, and flashbacks, which are a very specific kind of intrusive memory that causes a lot of distress for people, where you're really reliving, not just thinking or remembering, but going back in time and feeling like it's happening again. There can be avoidance or numbing, blocking out all memories, the total opposite. There can be hyperarousal, being easily startled, not sleeping well, having problems with concentration, and just negative changes to your thinking and your mood, being less interested in things, and kind of isolating at home. And when we think about the meaning of these kinds of traumas, we can think about, why did this happen to me? What does this mean about who I am, or about my relationships, or about the world, or about the future? And if we think about risk factors for developing PTSD, we can look at these three areas: what happened before the trauma, what kind of life or person were you before, what happened in the trauma itself, and what happens after. And just to summarize that quickly, I think the most important things that really come out of that is that it's the post-trauma risk factors, the things that are happening in people's lives right now. So things like ongoing stress and lack of current social support, that are really some of the very important things that can mitigate and make things better or worse, which isn't a bad thing, because this is where we're meeting people right now in the present. And this is where we can also help people. We can't go back and change things that have happened in the past. Oops. So just thinking about the way that we might approach trauma with people is, first of all, people have to be safe. So that's called phase 1 or stage 1, according to the work of Judith Herman, who's a psychiatrist at Harvard, who really started writing about trauma and sexual trauma and gender-based trauma in women in the 70s, 80s, and 90s. And so people have to be in a safe place before you can go in and do a stage 2 of trauma, which is looking at remembrance and mourning, telling the story of the trauma, going through all the details in a way that you can integrate that and create a life narrative that makes sense to you. And that's where some specific trauma treatments might be helpful. And the phase 3 is really, really important: reconnection, reintegrating into social roles and responsibilities, reestablishing a sense of self and relationships. And some of you might have seen this book by Bessel van der Kolk. He's been on the New York Times bestseller list for months or years, even with this book, The Body Keeps the Score. He writes that the ability to create symbolic representations of terrifying experiences promotes the taming of terror and the desomatization of traumatic memories. So in other words, if you can talk about something and if you can put it into words, then you can deal with it. That's what this means. Oops, sorry about that. All right, so now we're going to turn to spend a few minutes on refugee mental health, which is another large part of my work. I work in two clinics, one at the Canadian Centre for Victims of Torture and one at CAMH, which is called the New Beginnings Clinic. And some of you might, this title, One is Too Many, might resonate with the None is Too Many kind of Canadian government response to Jewish refugees during World War II. This is from a message from the UN, from World Refugee Day, where they called it One is Too Many. And refugees as a world problem is a growing concern. Every time I do this talk or update the slides, I'm adding a few more million people. So around 82 million people around the world are forcibly displaced. Some of those are within their own borders. That's 48 million people. So about half of them, if it had to move from a town, countryside to the city within their own country, about 26 million are identified as refugees and 4.1 million are asylum seekers, so claiming for the right to settle in another country. And mental health problems in refugees are often the result of ongoing violence, this forced migration, multiple losses, lots of everyday hardships when you've had to leave your home and life is turned upside down. However, the majority of refugees do well after reaching a place of safety. And one of the things that we do know with refugee mental health is that the presence of psychological distress does not necessarily indicate the presence of a mental disorder. So that's an important lesson for all of us, really, because when we're going through stressful times, we might be responding to a situation, but it might not be causing a kind of long-term pathology or kind of change in how we see the world. And when those stresses end, we might regain our balance and return to the way that we were able to function before. So when we look at kind of mental health in emergencies, really there's only a very small number of people with severe disorders, if we're talking about really things like psychosis or schizophrenia or severe depression, where people really cannot function. Those numbers might be 2 to 3% before an emergency and 3 to 4% after. If we're looking at mild or moderate problems like depression and anxiety, sometimes PTSD, we might be looking at 10% before and 15 to 20% after. If we're looking at what we call normal distress, then those numbers, we don't really know what they are before because people probably aren't in that much distress when things are going well. And the numbers after the emergency can be very high, hard to estimate. But that's the group that's going to need support to make sure that their normal distress or burnout or stress is not going to turn into one of these other diagnostic categories. And if we look at the main recommendations for how we manage this kind of refugee stress and distress during their acculturation or resettlement process in Canada, the key elements of this recovery process are empathy, reassurance, and advocacy. And we know that social support can moderate the impact of their trauma, reduce the severity of symptoms, and facilitate the recovery process. And some things that are really important to that are adequate housing, employment, and a steady income really are crucial to improving refugee mental health. And I would say the health of the general population as a whole. So there's some debate about, whether we should focus on trauma treatment or this kind of psychosocial approach for refugees. And my colleague Claire Payne has given some presentations and written about this idea of differentiating distress from mental illness. And this comes from the work of Alan Horwitz, who talked about distress and differentiating it from a disorder as a psychological outcome of stressful social arrangements. What could be more stressful, for example, than living through a pandemic now? So this distinction, if we're exposed to stressors like an acute life event, a stressful situation, a failing marriage, a lost job, conflicts at home or at work, this distress can persist as long as the stressful conditions endure, but there's no internal psychological dysfunction. And distress is a normal human experience and persists in proportion to this external stressful situation. Distress is not a watered down version of a mental illness, but it is something that will resolve once conditions can be improved. So that's why paying attention to these social determinants of health are so important. This is a quote from some colleagues at CAMH. The way that refugees are welcomed into a country where they live, whether they can work, if they're considered residents, and their access to education, training, and initiatives fostering social inclusion are fundamental factors in promoting mental health. And if we look at refugees who are having struggling financially, they are the ones who are going to be more likely to experience poor sleep, ongoing stress, depression, more bad memories. If people are at home, not going to their ESL class, not going out to volunteer, not meeting up with their community, not going to a church, a mosque, a synagogue, whatever, those people are going to be at home with too much time to think. And that's when, this kind of stress can start to creep into sometimes the idea of some psychiatric symptoms. Even for people that do well, I think as a group, refugees might earn far less than the Canadian average, even many years after arrival. So it does take time to reestablish yourself. An improvement of living conditions can really mediate and moderate the impact of trauma and contribute significantly to improving refugee mental health, often more than psychiatric interventions. So sometimes if I can write a letter for somebody to get subsidized daycare or a housing application or an ODSP application, or the kind of work that I do very often, which is writing psychiatric reports to help people with their refugee hearings so that they can be allowed to know that they're secure to stay in Canada. Those are some of the most important things that I do. And trauma treatment is actually a very small part of the work that I do with newcomers. But we know that with newcomers, it's really a lot more than PTSD alone. It's really the breakdown of their social fabric, family loss or separation from family, disruption of daily life, dismantling of everything that they've known from back home. So it's very hard to put like a specific medical diagnosis on your life turning upside down. And looking at the work of Arthur Kleinman again, who wrote about social suffering, and we talked about at the beginning, he's a psychiatrist and anthropologist at Harvard University. He wrote that suffering can't be usefully reduced to a psychiatric diagnosis of PTSD. And when we look at these issues, we're kind of looking at things that involve not only health, but also welfare, legal, moral, and religious issues. And so, for example, the trauma, pain, and disorders to which atrocity give rise are health conditions, but they're also political and cultural matters. And Derek Summerfield, another psychiatrist who has been critiquing a little bit the biomedical view of how we treat trauma and also export some of our Western psychiatric knowledge to other parts of the world, wrote that this medicalization of suffering infers that all suffering is pathological, an illness or a disease, and must be treated within a medical model. It obscures the political and economic causes, and goes on to say that suffering is inevitable for human beings and traumatic experience is ubiquitous. So to heal, we've always needed the institutions of society where meaning and culture is sequestered. Schools for our children, mosques, temples, churches, synagogues, work, healthcare, or sport, community centers or pubs, less treatment and more assistance with rebuilding the infrastructure which houses the culture's system of meanings. So moving on then from that to the topic of resilience and getting close to the last third of my talk. If we look at a definition of resilience in cultural context, thinking about exposure to a significant adversity, whether psychological, environmental, or both, resilience is both the capacity of individuals to navigate their way to health-sustaining resources, including opportunities to experience feelings of well-being, and a condition of the individual's family, community, and culture to provide these health resources and experiences in culturally meaningful ways. So what is refugee resilience? Well, refugees have been functioning individuals, healthy people who have taken great risks and overcome immense hardships. They have strong survival motivations and plan sufficiently to escape successfully. Refugees are people with enormous strengths and capacities to overcome adversities. It begins with early experiences and solid attachments. So many people have had strong upbringings before problems came to their hometown or home country. And we know that community support is really essential. Settlement services are vital. So a good settlement agency, whether it's Ptsd or JIAS or Canadian Centre for Victims of Torture and many others, where people can get together, learn English, start to figure out what kind of winter coat they should be buying, have computer training, get help with housing, all of that is really, really important. This is just a photo of my clinic team, and just as a reminder that these things happen as a team. It's very, very important, especially when dealing with a lot of difficult stories sometimes, to be able to have like a support group of our own to debrief and network with, and everybody has their own special set of skills. We work with social workers who are, irreplaceable and do a lot of networking with community programs and groups. And that's really a very fun part of the job. So just some considerations for psychological support and enhancing resilience. If we're thinking about this in this refugee population, how the experience of war, trauma, or torture can impact adjustment to life in a new country, the experience of getting help, expectations for therapy, family life, a sense of one's own future, and physical and mental health, as well as spirituality. And this leads me to the topic of post-traumatic growth, which is a kind of newer idea that's been written about, where having lived through a difficulty or a trauma, you can lead to changes in perceptions of the self, identify strengths and new possibilities, maybe realize that life has to be taken seriously, it's precious, leading to greater intimacy and relating to others, a changed philosophy of life, not going to waste time, new priorities, appreciation, and spirituality. And this is from the work of Weissenberger and also Tedeschi and Calhoun and many others since then. So this is an idea from a Japanese kind of form of art, which is a kind of pottery repair where You start with a perfectly good piece of pottery, but it's broken and then repaired with threads of silver and gold, with the idea that the piece is even more beautiful now. And so that links very well to ideas of resilience, because, you know, we all go through different things in life, and that's what makes people stronger and also more interesting. And getting through that process, through self-care, through thinking about our values, what keeps us going, whether it's our family, our children, religious, spiritual, or political beliefs, and finding connection is really an important part of that. So I'll just end with the last few minutes on some coping strategies to prevent burnout and enhance resilience. And some of you may have heard some of these ideas before. They're kind of simple but effective. What can I say? They're easier said than done. You know, we don't all do what we know is good for us, but it doesn't hurt to hear it one more time. So first of all, hold one focused, connected, and meaningful conversation each day. Hopefully we'll have a chance to do that in a few minutes. Attend to your spiritual and creative life. Sounds like you're also in the right place for that. Sleep at least 7 hours a night. I'm not sure we're all doing that, but we can try. Keep calm and turn off social media. Definitely a challenge, especially when there's 24-hour news and Facebook and Twitter and all the other things going on. But you know, these kinds of breaks from constant news are really important. And when I was preparing for this talk, my husband was referring to this talk that he heard from McGill, that Anthony Fauci, the COVID, you know, expert from the States, had said that people in the last pandemic 100 years ago probably had a much easier time dealing with the news when, you know, you got one newspaper a day in your town and didn't have like a barrage of things, and also things like following through with vaccinations and different things like that were probably also much easier when there was a lot less information, misinformation, and ways to know what's going on all the time. So eat sensibly. That one makes sense, but also not easy to do all the time. Exercise regularly. Make some time for affection and interpersonal closeness. Well, now that we're out of home lockdown, that might be sometimes a little bit easier. For people who want to go into things in a little bit more detail, there are some great resources online, you know, to do self-assessments for mental health, but also to look, like on the right side, for lots of different self-care and resilience kinds of tips and tools. There are a lot of interesting apps for meditation and learning breathing exercises and different ways to really maximize this. For people who might want to try something a little bit more formal, like a course, I think everybody knows about CPR and, you know, going to the Red Cross for swim badges and lifeguard training. But they actually have developed in the last few years something called psychological first aid, where you can learn self-care for yourself, mental health self-care as a course, and get actually a certificate for it. And then there's also a second level course where you can learn kind of also how to help other people. And so these courses in mental health first aid really should be out there in the community, I think, as much as CPR and things like that, because it's really, this is like the first level is not kind of in a psychiatrist's office. It's really out there in schools and out in the community. This is an invitation to anyone who's interested, who would like to join this mental health event that I've been part of organizing at University of Toronto for the last 7 or 8 years or so, called Mindfest. It's a mental health and wellness fair for people of all ages, from high school kids to seniors. There are exhibit booths, keynotes and lectures, workshops and activities. Before COVID, we were doing it at Hart House on the U of T campus, but now last year we were online, and we'll be online again in March 2022. So if we can keep in touch, I will send you the link, but you can see the address at mindfest.ca. And we'll be posting some of our keynote speakers and things very soon. If you do need help, I didn't know that there would be social workers here on hand, but please speak to them, speak to a family member or a friend, or to your rabbi, speak to your family doctor or pediatrician, contact your employee assistance program. There are lots of crisis lines that are available for support and can be completely anonymous. There's also a new website that was launched during COVID called by the Canadian government called wellnesstogether.ca, and the Mental Health Commission of Canada has some of the self-care and resilience tools that I showed you earlier. And of course, if things are very urgent, go to the nearest hospital emergency room or call 911. And thank you very much for your attention. And I think I'm pretty much on time, so that's great. We have a lot of time to chat and have some questions. So I will stop sharing, I think, so I can start to see people, or maybe I won't, depending on this webinar format, but I will see Julie and Julie will ask the questions.
Okay, thank you so much, Dr. Andermann. That was really a wonderful overview of trauma. I know it's hard to cram all that into 40 minutes, but I think we now understand the etiology of it a little better and the ways it can manifest itself, and how it's important to build resilience. And the resources and tips that you gave were fantastic. It really took up a lot of my questions. So, but I do have several questions that I still would like to ask you. And I'm just trying to see if we have the Q&A box. I don't see it in front of me. So I'm going to start with the ones that I received or I have. First off, I know you give us a lot of tips, but what would be the first thing that you would tell somebody if you see or recognize, or they share with you that they believe are experiencing extreme stress?
Yeah, I mean, I think if somebody actually, confided to me that was happening, I guess it would be just, to check in and make sure that in that moment that they're okay, and that there's, a way that they can be in some kind of place of safety, even for some moment of time. So in extreme situations, if you're in a situation of, let's say, domestic abuse, or if you're in, like a war zone, or your house just burned down, like that's probably the most important thing, is to have a roof, a blanket, a telephone, and a safe place to be. So those are, that's a time for kind of action and making sure that those basics are there, and then you can kind of talk about what to do next.
Great, thanks. Yeah, I guess there's such a range of ways of suffering, so it depends on sort of where you are and what you're doing. So what do you think about, I got this from a British website, but they've been known to say, keep a stiff upper lip, soldier on. I guess that stems from the war. Well, you said keep calm and carry on, just keep going, buck up. So what do you think about that attitude towards overcoming trauma?
Yeah, I mean, probably, I think there's probably a time and place for everything. And as I was saying, I think in that those, that phase-oriented model of trauma treatment really, to me, is like the template, like the gold standard of how to do things. So, if if you're not in the right time or place for therapy, because it's a time to kind of do that safety and symptom reduction, for example, making sure you're sleeping, making sure you're eating, making sure there's no substance use, making sure that someone's not suicidal, and that someone is safe and in a good place, you actually ironically have to kind of be in that better place to be able to sit down and do the therapy in a safe way, because you don't want to open a Pandora's box necessarily and then somehow have somebody flooded and make things inadvertently worse, So it's that first don't do no harm. You want to do an assessment, and psychiatrists are trained to do those assessments and kind of hopefully know how much to probe and how much to ask, but you might not want to do the actual psychological treatment until, well, in the case of refugees, maybe you don't want to do it until they have their papers to stay in Canada, until they've had their stamp that they can stay, because a lot of times a lot of their that anxiety and distress will dissipate, and there's just so much relief that they can stay, that you're not treating the same situation anymore. So I think that's also part of it. It's very hard in a crisis to do trauma therapy in a crisis. You can do crisis counseling, and a lot of people are very good at doing that, but that's different than trauma therapy.
So that leads to my next question. So often we hear after a traumatic event, for instance, a school shooting, let's say, that grief counselors are brought in to help those who were present or anyone at the school. Is it helpful for everybody to have grief counseling? As you said, not everybody reacts the same way. Not everybody goes through the same process of recovering or has the same reaction. So would the grief counseling be detrimental to a certain extent?
I mean, I think things that are offered, in the moment are important, but I think it's also important to look for, like, maybe the quiet kid or the quiet person who, didn't really take them up on that offer of counseling, in the hours or days after, but, is like staring out the window, kind of months later and not getting back to how they were before. So, there are a lot of people that will keep things inside, and, it's important to kind of track and kind of check in with those people after the time. I guess the other thing that I would say is grief counseling. I mean, we didn't talk about grief that much today, but, grief counseling is a very important component of kind of aftermath of certain crises like this. And sometimes we are dealing with grief, sometimes more than dealing with trauma. And, we know very well the steps for resolution and managing grief, especially through also spiritual means, not only through like a medical system or psychological or psychiatric system, but as a culture, people, have dealt with grief and grieving, since time immemorial. So there are, a lot of ways that that different religions and different cultural groups can handle grief very well for the most part, as hard as it is. So I would just have one word of caution about, what's called sometimes debriefing, which is, if people are brought in and then kind of made to tell their story kind of as a group, that can sometimes, right in the moment after something's happened, that can be a little bit difficult, because not everybody in the room might have seen the same thing or heard the same thing. And then you're sharing very fresh details, maybe from somebody who had their head under a pillow and didn't actually see what happened. So, you can sort of bring things to mind that might not have been there before. So if those kinds of things are going to happen, sometimes they're better done individually or with a lens of what we would call psychological first aid, which is kind of that self-care approach, and not pushing people to talk about details before they're ready.
Right. That makes a lot of sense. Thank you. I always thought about that when I saw things like that on the news. So I was always curious about that. You mentioned also about nightmares, flashbacks. If in fact that does happen, which I understand it does, what do you recommend? How do you go about alleviating those kinds of things?
Yeah, I mean, anybody can have a nightmare. We've probably all, had one in our lives or more. And, we know that sometimes there are just ways of having processed things that, were brought up during the day or during the week. And, there are different ways that our unconscious minds can deal with different kinds of anxieties or memories. So I think these kinds of nightmares that I'm referring to are things that are very fixed, and that really people are reliving in their dreams some some terrible event that's happened, really without any imagination, without any new details, or, kind of, it's really like a living memory sort of something that's exactly what happened. If people are starting to kind of think about a different ending or different things that they can sort of do to change the outcome, or something's like really like fantastical and not exactly the same, that already means your brain is working on it. But probably what it really means is that if you're having those kinds of dreams, it's kind of like your body, your mind's way of saying you need to deal with this stuff. And, if you don't talk about these things during the day in the right place and with the right people, then it's going to kind of come back and torment you at night. So it's probably a sign that there's stuff that needs to be grieved or talked about or, processed in some way.
Good. Okay, thank you. So it's sort of like a hint or a warning sign in a way. That something underlying is bothering you. I know that there was a question or two. Okay, so this question is, could you say a few words about attachment trauma and its impact on an individual throughout a lifetime?
Yeah, so this is a very big topic, and I think what they're saying is, we talked about like a single incident trauma, like a one-time thing, a car accident, a bank robbery, or school shooting, God forbid. But attachment trauma is when, from your earliest memory, you're raised in a family situation where you may not feel safe, or where you have to kind of feel that you're protecting yourself, or wary of the important people in your lives who are your caregivers. And that kind of trauma, can lead to different kinds of outcomes, what we call complex trauma. So it's something that's gone on over an extended period of time and really shapes your outlook of the world, your personality, and the way you cope with things from a developmental perspective. So that kind of trauma, is amenable to different therapies, is still also amenable to all of these self-care and coping skills. And it just needs a slightly different sort of approach.
What's an example of an attachment, someone who's experiencing attachment trauma? Not sure.
Well, let's say if somebody was raised in a home where they, couldn't feel safe, where there was childhood abuse or mistreatment or neglect, maybe it would be difficult to have those feelings of safety and security in an adult relationship. So there might be lots of instability with friends, with romantic partners, with employers, power struggles, different dynamics that kind of get in the way of what the person may hope to achieve, but just didn't learn those skills at the right developmental time to be able to learn to calm yourself down, or so on. So,
okay, that helps a lot. Thank you.
Mm-hmm.
Sometimes people refer to, I guess, again, flashbacks. But can you suppress a trauma? Can you suppress a extreme negative experience, almost to the point of forgetting it, and then does it come back again at a later date?
Yeah, that can happen. And I think there's some literature about that with Holocaust survivors, for example, who were so maybe keen and relieved to be able to start their new lives when they came to Canada or whatever country they ended up in, jumped into new marriages and new, continuing school and work. And then sometimes, if something happened that might have reminded them later about what happened, or with the aging process, sometimes with dementia or going into sometimes a senior's home or other things, that those might be things that might trigger with ill health or, frailty or age. There can also be people who just, really do block it out, because one of the coping strategies is to block it out and, avoid thinking about it. And sometimes that works up to a point. Sometimes there might be, something that you wouldn't really consider a trauma at all, like a small altercation or something like my boss yelled at me, and then suddenly the person like can't function at work anymore, and there's like a kind of breakdown, and you're like, why did this trigger it? And then you found out that there was like some big thing in the past that you didn't know about. So this was really just like the last straw.
Okay, so now I'm going to move to the topic of medication.
Okay.
Obviously, a lot of people now take, or there are many prescription medications to help individuals cope with stress and disorders. Probably we know a lot of them already. Maybe you can refresh us. But what are your thoughts about medication? And can you also talk about the new use of psychedelics or psilocybins that are now becoming more and more useful for coping situations?
Mm-hmm. So first of all, like just to take a step back, I mean, we really do approach all of our patients in clinical work with what we call a biopsychosocial, and sometimes a biopsychosocial, spiritual and cultural formulation. So it's understanding people as a whole person. There's the biological part, your genetics, your family history, your physical health, substance, history, all of those things comes under biological. The psychological part is like your upbringing, your resilience, your personality, your, coping skills. And then the social, we spent a lot of time talking about social determinants of health and like life stressors, job, house, friends, all of that. So, within the biological, I do think there's a place for medication. And we do use medications for PTSD and for this kind of anxiety and especially for sleeping problems, because if people can't sleep, then they're not going to be able to have the most effective coping and problem solving. So of those categories, like I won't name specific ones probably, but these are kind of in a way generic antidepressants that we use for anxiety and depression and PTSD. There's treatment guidelines, and some of these antidepressants are useful for trauma disorders as well. It's important to choose non-addictive medications, especially when we're thinking about sleep. Things like benzodiazepines probably not ideal because they can be habit forming. People can get used to them. And part of the treatment is to be able to learn that the world is not an unsafe place and that you can go back slowly and when you're ready out to do things again. So we don't want to kind of take all of the anxiety away, but to learn that you're able to challenge that in small, manageable ways and get back to doing things in life again. There are some specific medications that are good for nightmares, and we've learned about those from studies with Vietnam veterans, and they're actually used quite a bit these days. So that's my take on medications. But medications, I don't think medications work that well if you're sitting alone in your house. I think if they work well combined with some kind of counseling or therapy, and also going out and doing some of those kinds of healthy coping behaviors and finding something meaningful to do.
I know, I appreciate that. I know you can't be too specific, but I think a combination is exactly the best way. So along those lines, what do you do when an individual, let's say a family member, withdraws? And really you can see that they're not interested or refusing treatment and just continue on going sort of on a downward spiral. How do you start that process?
Yeah. Well, I guess, I think there are many different roads to healing, and not everyone might choose to want to, talk to their family doctor, and sometimes even less, sometimes to talk to a psychiatrist or a therapist. There's still a lot of stigma around mental health. But if people would be happy talking to maybe an old friend, someone from their generation, maybe their rabbi or someone from their congregation or a neighbor, like maybe, it's hard sometimes for families to feel maybe that they're burdening, a younger member of the family or a child or, with some of their problems. And I think that's also what happened, like with some of the Holocaust survivors after they came to Canada, is like a lot of people, and I heard this from my grandmother, like didn't want to hear, like the people who were in Canada and, were not newcomers, like they were like, it wasn't really a place where you could talk about so much what happened for a long time, and so sometimes it's just something that, you can only really share it with somebody who's been through the same thing, or, finding someone of the same experience or generation where you feel that you might be able to be understood if you bring it up.
So do you recommend support groups versus individual treatment?
I think there's definitely a big place for support groups for sure. I think like with the example of the debriefing, like the support groups, people have to be ready for what they're going to encounter in the support groups. So some groups are peer led by people with lived experience who have been through whatever shared experience, and that could be something like an AA group, or where everybody in the group is kind of dealing with the same kind of thing. And, but with trauma groups, you do have to be just a little bit cautious that, you're not going to hear something that you're not ready to hear, or that you're not feeling that you can deal with. So I think they do have to be moderated and kind of taken with some caution, so that everybody feels safe and comfortable in the group.
Right. Okay. Thank you for that.
Yeah.
I'm just looking. I don't think I see any more questions. I think I've sort of alluded to some of them already in my questions. Let me just go through them. Do you have any other things that you want to add before we move on?
Well, I think these questions have been great, and I think it's just so good to have a place for conversation and a place to get together and to think about mental health and stress and how to how to manage, how to move on. And I think from some of the people that have lived through the most, I find them very inspiring, and very, you can always learn from these different experiences. So I think it's it teaches, I think, me more than I teach people sometimes. Yeah.
Well, it's been wonderful. I think I'll end the Q&A now. I would like to thank you, Dr. Andermann, for your thorough and very informative responses, and for sharing your personal stories as well as for imparting all the educational aspects of your talk tonight, and especially knowing that resilience and coping strategies certainly go a long way to moving forward. So I just want to close with a few sort of housekeeping items here. In order to express our gratitude towards Dr. Andermann on her talk tonight on trauma, the Luke Sklar Mental Health Initiative Committee has made a donation to the African Asylum Seekers Fund held at Holy Blossom Temple. Holy Blossom is continuing to actively support the resettlement of Syrian and Yazidi refugees, working collaboratively with JIAS, which is the Jewish Immigrant Aid Services for Newcomers. Holy Blossom is right now asking for the support that will be needed to welcome 9 people who are awaiting final permissions to travel to Canada. In addition, Dr. Andermann has graciously donated a copy of her grandmother's Memoir of the Holocaust. She wrote this book as a memorial to her family who perished at the hands of the Nazis, and a tribute to those people who helped them survive. at the peril of their own lives. We will be pleased to place this book in the Luke Sklar Mental Health Initiative section of the new Holy Blossom Library. And inside there's an inscription just thanking Dr. Andermann for speaking to us tonight. So hopefully one day you'll come to Holy Blossom and you'll go to the library and you'll be proud to see the book there.
That would be great. Thank you so much. And hearing
Sure.
about the African Refugee Initiative and Yazidi initiatives also. I've met a few Yazidi clients at CCVT. It's such important work. So it's wonderful that you're involved with that.
Good, I'm glad. Well, our pleasure. Thank you again to JF and CS for standing by with support from Dana Frischman and Mariana Gendelman. And I think that Rabbi Goodman posted the number and the emails previously. For those who registered, you will receive a survey by email in the next day or so. So please take the time to fill it out so we can, it helps us to plan future programs. We will also be providing you with some resources from this evening's talk. Also, the talk will be recorded and should be available in the next little while on our website under the Luke Sklar Mental Health Initiative. Just one or two more things. We also very much would appreciate your contributions to the Luke Sklar Mental Health Initiative Fund, which allows us to educate and support the community in the areas of mental health. We wish you all well and that you find some comfort in knowing more about why and how we experience trauma. And we have acquired some new tools to help us repair and mend the hurt. Thanks to all of you for joining us this evening, and good night.
Thanks. Bye, everyone.
Bye.
Take care, everybody. And Julie, we should say thank you to you as well. We really appreciate it.
My
Okay, everyone.
pleasure. Thanks
Take
again.
care.